Hello, everyone. Well, we're in that deep, dark place again, and unfortunately, we're going to have to talk about it tonight. Hopefully, it'll be a learning experience. It may be a little painful, but talking about complications is something that we don't want to talk about, but we have to talk about it because it keeps happening. And there was a patient seen in a med spa recently, right near me, and patient wanted her lips done, and she was treated with some filler in the lips, and things seemed to go okay initially. And as I understand it, the technique was this kind of crazy, I consider it a crazy technique. And I consider this a crazy technique because it's very painful and it goes right across the path of the artery. And hi, Heather. Good to see you again. Long time no talk. And so she went home, apparently, with no bad outcomes. And then later that night started to notice some discomfort. And in the morning, woke up and had kind of like this big discoloration on the upper lip. She called the provider, and the provider, got somewhat nervous. She sent her a picture. She had her come in. So far, raise your hand or say yes if you think this is worrisome. Anyone think this is worrisome? Yep. Carmel, you think? Hi, Carmel. Got the call out on time today. So patient calls, treated the day before, discoloration here. Sort of a darkish, bluish, reddish discoloration. So patient was brought in, had no subjective complaints of pain. Hey, Austin, good to see you, man. Got my usual posse assembling tonight. And, was talking to the patient. Patient didn't have any subjective complaints of pain, but noticed the area was getting sort of worse looking. And so the nurse decided to inject some hyaluronidase. Hey, Maddie, your sub's here. Thank you. Your junior trainee is here with us tonight, helping out. Hope you're enjoying New York City. Hey, why don't you guys let us know where you're from? I like to see if you guys are from outside of Boston. Just let me know where you're calling from. It's always interesting to see people calling from, or not calling, but listening from a distance. So she goes into the med spa, has her lip treated, which with a technique that I don't think is great. And the next morning she comes in and she's got a discoloration. So the nurse who treated her started using hyaluronidase, and she used like 3 vials in one upper portion of the lip. Patient went home, and what do you think happened? Patient sent a video in with her lip kind of flipped inside out, and it looked all discolored and darker, and still no subjective complaints of pain. Pennsylvania, welcome Pennsylvania. Patty, thank you for listening. Brooklyn, New York. Oh, that's right. Let us know where you're from, guys. It's always interesting to hear people from all over the place. So she sees the video of the patient's inside of her mouth. Her mucosal surface looks darker, brown, blue, red, whatever color. She says, come back in. Come back in. Patient comes back in. She treats her with 5 more vials of hyaluronidase. So she's had a total of 8 vials of hyaluronidase, which I think sell for like $75 a piece or something like that, in this area. Now the patient's complaining of pain because she's been injected. So, hello, Connecticut. Thank you for aesthetic nurses calling, is talking. So she's gotten 8 injections, 8.8 cc's of hyaluronidase into this part of her lip, for a situation where the patient never had any subjective complaints of pain. What am I not mentioning to you? What is the number one determinant? Well, first of all, let me back up. Who thinks this was a great treatment for this patient? Wave to me if you think it was a great treatment for this patient. Does anyone know what this patient was being treated for? Presumably, this patient was being treated for an occlusion, and this was the first time this nurse had quote-unquote seen an occlusion, so she was very aggressive before she really ever called for help or for a second opinion or anything like that. And I don't know, yowza, that's right. I personally have never seen, nor have I ever heard, have you, Heather, of an occlusion that was pain-free? An occlusion where the patient never complained of pain. But what didn't I mention? What didn't I tell you? What do you all want to know to tell me whether or not this was an occlusion? You're all thinking probably, what was the capillary refill like? Because that's a sine qua non. That is the diagnostic determinant of an occlusion. If you have normal capillary refill, can you have an occlusion? Hello, Tracy. Heather says never. Heather says never. Capillary refill and type of product, good, excellent, yes. Pain is always a component of an occlusion. Even if, remember there's vascular occlusions, right, that are both venous and or arterial, right? So an arterial occlusion, there should be no confusion about that. It happens right away. The area blanches, the patient's in incredible pain, you pooping your pants because you know it's something really bad, and you got to treat it right away. That's pretty clear cut. Venous occlusions can be more indolent, they can be harder to pick up, they can be a little bit of a delay, but they're still uncomfortable, they still hurt. So here you've got a patient that, in my mind, had a bruise, right? Because of this technique I'm talking about where they're going across the vermilion. And instead of assessing, are you in pain? Let me test your capillary refill. Let me watch it for a little while. Let me see what's going on. Let me call somebody. Let me get their opinion. Let me take a picture. That's the other thing. When people are doing capillary refill, have you ever seen them go like this? Yeah, look, it's normal. See it? It's normal. That's not how you do capillary refill. That's not how... Hello, Tracy. That's not how you assess capillary refill, at least not correctly. So when you're assessing capillary refill, you have to hold your finger on or whatever, your pen or whatever you have, but you have to hold it there long enough to get all the blood out. So you have to hold it there for I tell everybody 10 seconds. Just really hold it, make it blanch, and then let go, and then count. You see how that just went right back to normal color? So if you're going like this, you're not really doing anything. You're not really assessing anything because you're not pushing the blood out. So make sure you hold it long enough to assess. I will bet you that if you assess that patient's capillary refill, it was normal, right? So if it's normal and the patient's not complaining of pain, why are we using 8 syringes of high hyaluronidase and actually creating a painful problem, creating an asymmetry, creating a terrible thing? So my point to you is that if you don't know what an occlusion looks like, if you've never dealt with one, and you think you have one, call someone who has had that experience. Call someone that knows more than you. Call someone that maybe knows the same amount as you, but maybe has seen it, whatever. But as long as there's good capillary refill, are we in the clear with that bruise? Yeah. Mm-hmm. Yeah. All of us have seen bruises before, but maybe when they're on the lip, they look a little different because all you have between you and the patient is a thin layer of mucosa, right? And the blood vessels right below there. So bruising is bruising. And also the time course is wrong, right? The patient was perfectly fine the whole night, and then the next morning, quote unquote, woke up. Maybe she had a fitful night. Maybe she did something that got her heart rate or blood pressure up. Maybe she had sex with her boyfriend or whatever the hell. But that's, during those first 48 hours, you usually tell patients, don't get your heart rate or blood pressure up because this kind of thing can happen, right? The patient gets their neurotoxin or filler, and then they think everything's great, and they go to the gym and work out, whatever. They come home and they got this big bruise on their face. What's the mystery there, right? This always happens. You put a hole in someone's face in multiple little vessels, and then you get a little clot. You hold it for a minute, you get a clot, and then the patient goes out and gets their blood pressure and heart rate elevated. What do you think happens? The little clot blows off the vessel, and you get bleeding, and you get a bruise. It's not a mystery. But then to go and treat that with 8 vials of hyaluronidase, I don't even know how you put that much hyaluronidase in a lip. But if you do have an occlusion, and as soon as you start with your first vial of hyaluronidase, the patient already starts to feel better. But if they already felt good, what are you even treating? And it also starts to look better right away, except if it's a bruise, it doesn't. You see where I'm going here? You can keep treating a bruise with hyaluronidase. All you're doing is helping the bruise spread, right? Because you're dissolving the connections between the cells, and you're opening up all the doors, so the bruise is going to look worse. So the patient calls back and shows you the video of it looking worse because now it's gone inside the lip. And then you treat it with more hyaluronidase. Not a good look. So, hey, where are you guys from? If you're from outside of Massachusetts, let me know where you are and we'll wave at you. Hey, Nina, thanks for joining. We're talking about bruises being treated like occlusions and people not being sure of what they're doing. 2 weeks before that, saw another patient that was treated in New Hampshire. First timer, got voluma, Volbella, Velour, some Botox. Came in with this kind of look, big swollen face, almost unrecognizable. About a week later, somehow she got to me. I don't know exactly how, but she came in and, I mean, her cheeks, you could have like bounced a quarter off her cheeks. I mean, they were so hard and so full, and it almost made her eyes close, and she was in, terrible pain, and she couldn't chew, couldn't open her jaw. I was like, what the hell happened to this woman? And we couldn't get the records. The nurses were being difficult giving us the records. The patient was a terrible historian. And so I ended up, dissolving. I think I used 3 or 4 vials of hyaluronic to dissolve all of her cheeks and some of the other areas. And she called back and had now these huge areas of, like, they look like boils or wells, like areas that were sort of filled with pus and fluid. And I was like, what the hell is wrong with this? And then she came back and she was sending us all these photos, and with this big abscess right here on her cheek. And I was saying, listen, you've got to get to the emergency room. You've got to get that eye indeed. It's right near your eye. It's not too far from the brain circulation and eyelids in the eye circulation. You've got to get help. And she was just very reluctant to do it, and we couldn't really understand it. But the really interesting thing was, all this woman really had were some injections of filler. But why did she get all these infections and have abscesses and need to be, have them lanced? Hey, Connecticut. Hey, Nina Silva. Great topic. Yeah, it's always good to talk about terrible things, isn't it? Only because, listen, you know what? You got to know what to do in these situations, and you got to know what not to do. And in that first case, you know what? You gotta know when to call for help. If you just don't know and you're just randomly throwing hyaluronides at people, you're not really helping. You're not really learning anything. You gotta think about what you're doing. So this patient comes in and she's had multiple infections. Now she's a couple weeks out. I'm worried that she's going to get osteomyelitis from persistent infection right on the malar bone. And I said, listen, you got to get someone in New Hampshire to help you. You can't keep driving 2.5 hours down here. You just got to get someone who's going to follow you up there. But I'm thinking to myself, why did this patient get all these infections? She didn't seem immunocompromised. She's not on any medications that would do that. She is a smoker, certainly which suppresses your immune system. But no really good, really good idea as to why. But honestly, in my mind, that's a technique issue. Like, that's a complication. That's a result of bad technique. Because when you have a gel that's at body temperature and you put it into a patient's face, which is the perfect culture media temperature, and gel with blood around it is even better, growth media, you get an infection. So I chalk that up to the fact that the patient, really didn't get great follow-up. I think she was upset that this happened to her, that her face swelled like this. But I've never seen anything quite like it. Like, literally her face swelled so much that she didn't even look like it. It looked like literally like she'd been beaten. I was like, are you sure that's all they did was put in 4 syringes of filler? So clearly there was a technique issue there, and there was a lack of follow-up issue there. And I think when she gave them some pushback, they were like, let's get rid of this patient. And the person who treated her wouldn't see her, which is a huge, huge mistake. You never want a patient with a complication to feel abandoned. That is like the cardinal sin. That's almost like saying, please sue me. Please file a lawsuit against me and try to take my license away because I'm a bad injector, or even a worse person. So when you have a patient with a complication, whether or not it's your fault or the patient's fault or nobody's fault, you've got to support that patient. You've got to make them feel like, no, we're going to get you through this. We're going to make it better. We're going to help you. If I can't do it, we'll have someone else come in and help as well. You've got to support that patient, or else, honestly, abandoned patients, patients who have, some sort of adverse event are already upset. But when you compound that by abandoning them and making them feel like they've done something wrong or whatever, I'm telling you, it's a recipe for disaster. And I've seen it multiple times. Enough said. Another patient, a few weeks before that. Now, these are all patients we've seen in the last month or so. So I know that I'm only seeing a very small number of them, so that makes me think this is happening a lot. Tell me where you guys are from if you're not from Massachusetts. Hey, Sarah. Patient was seen by someone who flew from California to Boston to treat patients on Cape Cod in Provincetown. Treated this patient in the chin area. Patient immediately complained of severe pain. Was told, it's just part of the injection. It's a sensitive area. Person flew back to California. Patient continued to have 10 out of 10 pain. Couldn't open his mouth to eat. Couldn't even chew or talk like this. It was so painful. Person flew to California. Didn't really want to hear from this guy again because she was busy going to the next place. Was barely in the country, right? 3,000 miles away. Person didn't know what to do. Finally ended up in our system. Hello, New York. Good to see you guys. Came to us and had a beard, like a little kind of goatee thing going on. And underneath the beard, you could see there was necrosis here. But it started down here. So this person had kind of an unusual thing. The mental artery is here, right, for the mental frame. The submental artery, which usually most people are very, very small. It's not really a significant artery. In this case, was a very big, significant artery, and the person had an occlusion of the submental artery. Now, this was a couple days later. This guy was, crying in pain. So the person was treated with some hyaluronidase after one vial. Again, let me back up. I'll give you more. Very delayed capillary refill, more than 3 seconds. Very, very painful. Very tender. And after one vial of hyaluronidase, went from a 10 to a 5. That's an occlusion. No question about it. Don't need any more information. That is an occlusion. Textbook recipe right there. However, so we couldn't even shave his beard off because it was so painful for him. So we gave him some pain medicine, we numbed him up, and we were able to kind of shave everything off and continued treating him with the hyaluronidase. Now, miraculously, he did not go on to full-blown necrosis. We got him just in time. It took a week or two before he really looked great, but, he's kind of scabbed up a little bit, had a little bit of superficial loss of the epidermis, but overall a good save. But here again, the point is, don't treat a patient if you're not going to be there to take care of them. Who are you that you're just flying around the world, occluding people and then driving off or flying off somewhere? That's such a bad standard of care. You probably don't even have a license in Massachusetts. You're probably committing a criminal act right there. Practicing medicine without a license. You can go to prison for that. So who are we? Who are these people? And why are we letting them do this? It just makes me sick to my stomach. And thank God, he came to us and we acted emergently to help him. And he was a save. But that was a close one. And those things make me sick to my stomach. And I know it's happening. Should we charge for the treatment of someone else's heirs? Yeah, you do. You should charge someone. This patient that saw me, I knew she was going to require a lot. I charged her $1,000. I said, you can come back as often as you want. You can get as much hyaluronidase as you want. That way it was just done. But listen, why are you going to pay for someone else's mistake? Listen, the patient's got a complication. We all feel for them. But, you're running a business, not a kiddie daycare, right? You're helping people. You're taking care of something that someone else wouldn't or didn't or couldn't, right? Because you're good enough, you're nice enough, you're professional enough to do that. So, yeah, you know what? If your face is at risk, you'll pay anything to anyone, anytime to do anything that's going to make you better, right? It's a critical thing. Don't gouge the patient. Don't take advantage of them. But, cover your costs. Cover your costs and That way you feel good about it, and they're grateful. Hello, Colleen Daniels. Good to see you. You've been a little bit absent lately. We're looking for more of Colleen. So these kind of things, talk about who you are as a person, who you are as a professional. Are you doing it just for the money and doing these terrible things to patients? Are you doing it because you care about people, because you want them to get better, because you're proud of your work, you're proud of what you do, and you're all about it? So that kind of says a lot about you. And these last 3 cases I told you about, I think are happening all the time. That's why I'm talking about this dark, dark thing tonight, right? But, we all know about occlusions. At least we think we do. In the first case, that person thought they knew they had an occlusion, but had no clue what they were doing. And I'll review that case with them and explain to them what they should have been thinking and doing rather than what they actually did, because that ended up hurting somebody. Patients should also educate themselves. I see so many people run to IG popular injectors. Yeah. IG popular injectors without medical licenses. I don't even know what to say about that. I don't. If your whole world is based on what you see on Instagram or social media, then I feel very sorry for you or the patient who does it, because you could be anything and anyone you want on IG, and there's no verification, there's no way to credential it, there's no way to vet it. So I'm just like everything else on the internet. You've got to be really careful about it. You have to not get caught up in the trendy craziness that's around us. You got to be like a reasonable person, and use your brain and your eyes and talk to other people who've been treated by these people. You know what I mean? Just make sure you're going to someone who knows what they're doing. And if they get a bruise on the lip, are they going to treat you like an occlusion? If you get an occlusion, are they going to be in another state, in another town, and not answer you? Are they just never going to be available? Whatever. Are they going to give you an infection because they have bad technique? Listen, most people in this industry are in it for the right reasons. I just found out the girl that I used to see a few years ago in New York was on probation for not having medical director and administering Juvederm as an RN. A girl that you used to see. Wow. Like, what is going on here? So when stuff like that happens, it gives the entire industry a bad name, right? It gives us all gets on the front page of the newspaper, and all of a sudden you've got some governor or some state like Texas or Rhode Island or South Carolina recently saying we have to stop nurses from doing this. We have to stop them because they're not good. They're blinding people. They're they're doing it without a license. They're doing it without orders. It's this far away, folks. These 3 cases I'm talking about all happened within the past month, and they just happened to come to me. Someone sent them to me, But I know a lot of them don't even know me. They're not coming to me. Who knows what's happening to them. But if it gets to the Board of Registration of Nursing and Medicine and enough of them happen, kiss it goodbye forever. It doesn't come back. Anyway, enough of that. It's really depressing. Other complications we know about: bruising, hematoma, infection, all technique related. Listen, bruising can happen to anyone, but if it happens to you a lot, if you're getting hematomas, if you're getting all these infections, and you really have to check your technique, because that is like 90% avoidable. And watch someone who knows what they're doing. By the way, if you guys want to train with us, if you want to come to our school, click on the link on our bio. You see all this stuff. People always ask, can you mentor me? Can you teach me? Come to our school. We can teach you. We can train you. We can teach you how to do all this stuff. You come to our cadaver class, which is my favorite because I teach that personally, and I really get a kick out of it. And I think it gets better every single time. We're doing the retrobulbar injection for blindness. We're cutting down, doing the tear trough. We're doing the temple. We're doing stuff that no one else is doing. Not even that I want to show you guys how to do it. I want to show you why you shouldn't do it in some cases, right? Why you should stay out of the temple, why you should stay out of the tear trough. But that's a whole different thing. So if you're interested, go to our bio, click on the link. Will there always be serious pain associated with occlusions? I don't know what you mean by serious pain. Certainly with an arterial occlusion, it hurts like hell, because basically you're making it, the area ischemic. It's like when you have a heart attack and there's no blood going to your heart. Does that hurt? Yeah, like hell. It hurts and it radiates down your arm. Try to put a tourniquet on your arm and see how long you can tolerate it before it starts to hurt so bad you have to let the tourniquet off. Doesn't take very long, even like if you're drawing blood on somebody, right? So yeah, anytime there's a vascular incident, whether it's venous outflow or arterial inflow, it freaking hurts, right? And everyone has a different pain tolerance, but it hurts and it keeps getting worse until you make it better. So yeah, if a patient's like, yeah, yeah, I don't feel anything. It's good. They don't have an occlusion. They don't have an occlusion. So, that's got to be part of the differential diagnosis. That's got to be part of the question that you ask and part of the answer you get from the patient. So those are two important things. How do you know? I think the biggest complication that I've seen, I recommend your school 100%. Thank you, aesthetic nurse. We appreciate that. We try very hard to be the best because I think the level of aesthetic education in this country is horrible. There's so many people trying to get it, and there's so little available that's really quality that we end up doing things that make people think they're better than they are, and they end up hurting people. Anyway, the most common, I'm going to call it bad outcome or adverse event that I see in patients is too much filler. I think it's terrible. How do you know if a patient's had too much filler? Because you look at them and go, I know you've had filler. That to me means you've had too much filler. If I can look at you and go, she's got filler, that means to me she's got too much filler. That's bad to me, right? And I think, it's kind of like in the old days when we first got fillers for the lips and we were using fat and collagen and everything. We made everybody look like this, with big lips and big monkeys, if we made everybody look like that, because we just didn't know what to do with it. We didn't understand, what beauty looked like, and we didn't understand how to make people look better. And the same thing's happening. We couldn't make people's lips big enough. So everyone had these huge lips, and then everybody was like afraid of lips, and everyone wants big lips again. Everyone was afraid of lips. So now we're in that, like, we want big lips again. And clearly, if you look at someone and go, oh my God, the first thing you see on their face is their lips, it's too much. I mean, if you look at any beautiful woman on the magazine cover of Elle or whatever the popular magazines are, I don't even know. But they all look beautiful, but they don't look like there's lips and then there's a person behind the lips. Or like, oh, there's cheeks and there's a person behind those cheeks somewhere. It's all like it all fits together. It's not like they're beautiful because they have, it's beautiful because the whole thing fits together. And looking natural is really part of being beautiful. Because if your eye keeps getting hung up on the fact that their cheeks are so big, or their lips are so big, or their jaws are, whatever it is you're doing, that's not creating beauty. That's a technical exercise where any monkey can do that. Like, you can teach anyone. What's really important is for you to look at someone and say, I don't know what she's had done, but man, she's beautiful. That's beauty. It's not like, oh, I'm glad you did her cheeks because she wasn't. That's not beautiful, right? So understating beauty or undercorrecting a little is way better. Kate said, I learned from you less is more. Yeah, is way better than overtreating somebody, because that, when you cross that line and start to morph, my patient was talking about this today. I was like, how do you know so much? He goes, I know that if you put more there, you're going to morph me, blah, 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 blah. So one of the things that I think is really important is, like with this patient, I said, show me a picture of yourself when you think you look your best. So, of course, she pulls out a picture of herself. She was 20 years old, and she looked like a freaking model. I was like, okay, I see. You never had big cheeks. So I don't want to do your cheeks. And I thought I did, but after seeing that picture, I don't want to do your cheeks because that's really not where you've lost it. And we went through where the losses had occurred. And see, that's kind of how we should be thinking, because if you just treat everybody the same, you're changing them. You're morphing them into what you want, what you think. You're not replacing what's been lost. You're not looking at that person and go, oh, I see you've lost a lot of volume from your whatever, so we're going to replace that. I see, oh, you never had big lips, so maybe we'll do a little bit. So that kind of gives you a game plan, because people really kind of still do want to look like themselves. They want to be recognizable by people who know them or maybe haven't seen them in a while. So that to me is the biggest adverse event, is overtreating with fillers. The other thing I want to talk about quickly, because I know we're going along with that, but this is hey Greta, hey Sid, good to see you guys. The other thing I want to talk about just quickly is, in terms of complications, where do you think we see more complications, neurotoxins or fillers? If you think it's fillers, raise your hand or send me something. It's neurotoxin. I have a small clinic in Connecticut, but live in Mass. I'm certified in Europe and in Mass for aesthetic. I injected my client in Europe, but I can't here. But for education going forward, can I still be coming? I'm not sure what that means, but if you want to DM me, I can maybe answer that. I don't have time to do it all tonight, but we'll help you if we can to get you licensed and going. Why? So with neurotoxins, they're done far more often than fillers, so you see more complications. Fillers, the complications are more devastating, right? And it can be permanent and deadly. So we talk about them a lot, like those first cases. But for me, the big problems, that I see more often, complications in the forehead, the eyelids, and around the mouth. Why? I still think people don't understand the forehead. There's 4 sets of muscles pulling down and one little muscle, the frontal, well, it's a paired muscle pulling up. So you got this one kind of weak muscle and 4 muscles pulling down, gravity pulling down, volume loss deflating you, right? So why do you think we end up with so much brow ptosis? Because people don't understand that you have to maintain frontalis function. People are okay with a little bit of motion of their forehead, but if you drop their brow or drop their lid, they're really unhappy. And there's nothing much you can do about it. So you have to understand the interplay between the frontalis and all the depressors around the eye, right? The procerus, the corrugators, the lateral bicularis, the depressor in the medial part of the nose. If you don't understand that, please go learn it. And the other thing is asymmetries. I see asymmetries in the forehead all the time. Why? Oh, because they're pre-existing asymmetries. Everyone's forehead is asymmetric, and if you treat it the same without analyzing, without having good assessment skills, you're going to maintain or actually make the asymmetry worse. So why don't we back up, and instead of just jumping in with a syringe like you're crazy, syringe happy and Botox happy, look at the patient, make them animate, show them which brow is higher. Think about, do I want to put more on the side that's already, already higher, or do I want to put less, or do I want to lift, do I want to inject the tail so that side goes up? You have to really think it out and plan it out, because if you don't do that, you're just treating everybody the same way, you're not a good injector. You're only as good an injector as you are someone who can assess the patient and come up with a plan. So try to be more analytic. The other area we see a lot of problems in is the perioral region. I see people like this all the time. Smile. I am. What happened? They hit the DLI on this side, so this part isn't coming down. When you smile, your lower lip is supposed to come down. The action of the DLI, the depressor labii inferioris, does that. If you accidentally hit it and the person smiles, the side that was hit doesn't go down. Why is that happening? Well, people don't understand the interplay between the DAO, the DLI, and the mentalis. They're all interdigitated. They're all on top of each other. So if you come to a cadaver class, when we peel it all back, we'll show you how they overlap each other. So if you go too high in the DAO, you'll hit the DLI. If you go too high in the mentalis, you'll hit the DLI. If you hit the DLI, that side doesn't work. So you have to know where to inject these muscles, where it's safe, and obviously people don't, because I see this all the time. And the other thing, of course, the big one, is ptosis of the eyelid. Saw one of those 2 weeks ago, pretty much half the way down. How did that happen? I also saw one patient that had diplopia, and of course she was a nurse, right? So whenever she moved her head, one of her eyes couldn't move right because somehow they got it into her eye and hit the medial rectus, as part of the intraocular movement. So when she was a colonoscopy nurse, and whenever she moved her head, she'd see 3 things. Which one's the patient and which one's not. So she couldn't work for months. It took her months because that muscle is very small, very sensitive to neurotoxin. So people not understanding that lateral injection is right above the levator muscle, literally millimeters away. And if you go too deep, which you shouldn't because it's a very superficial muscle, the insertion's right there, and it indents the skin so you know it's close to the surface. If you go a little too deep or a little too low and you get some neurotoxin, it prevents the muscle from opening your eye. Terrible thing to have happen. It recovers, but do you want to walk around like that? Or have one of your patients walk around like that? Oh, who did that to you? Oh, I'm never going to that med spa because they make you maybe they're going to lose my vision. Something terrible can happen. So, pay attention and really understand and learn the anatomy. Most of these complications are avoidable, but they're not avoidable if you don't try to avoid them, if you don't understand and make an effort to really understand the anatomy. So again, you're only as good an injector as you are an anatomist. I want you to understand the anatomy as someone who can assess the patient. As part of our course, we do an assessment segment. It's actually, in the beginning, a little bit painful. Because what I tell them is, look, when you're looking at a person's face, you want everything to look the same. You want the brows to be the same height. You want the eyes to be the same height. You want the lips to be symmetric. You want everything to be symmetric. So your eye kind of scans the person. Oh, everything looks good. Everything looks... Well, but then if you start measuring and you start looking and you force your brain to accept what your eye is seeing, not vice versa, because your brain will say, oh yeah, Russo's eyebrows are pretty much the same, but then my eye says, well, look, it looks like this one's a little bit higher than this one, isn't it? And then you start really drilling down on these people. Tell me what you see. And they always start telling you what they think they see. I said, no, tell me what you see. And I'll stop the class, and we'll have half the class on this side, half the class on this side. So, okay. How many people think the right side of the face is fuller than the left? Half the students raise their hand. How many people think the left side's fuller? Half the people raise their hand. So it's like, okay, all of you are looking at the exact same face from the exact same angle, because they had the patient turn the face both ways. How could half the people see this and half the people see the opposite? When we can measure it. It's measurably different. And it's because it's like, don't worry about what you think she's going to say. Don't worry about what you think I'm going to say or what you think you should say. Just tell me what you see. And it sounds simple. It's really hard. It's really hard to see. But once you see it, you can't unsee it. Like once you see the brow is higher, I have them turn away, look back. Turn away, look back. Keep doing that until you see it. And finally they see it. They're like, how did I not see that before? Well, you train yourself not to. Your brain doesn't want you to see asymmetry. It wants everything to be beautiful and rosy and symmetric and lovely. But no one's symmetric. Every single patient. Then we start following the face now. So if that brow's higher, what do you think that frontalis muscle is going to be like? Which eye is higher? Which nasolabial fold is going to be fuller based upon what we are doing? And you follow all the way down the face and you're just like, how did I not see that? And they start looking at everyone different from that point on. And again, the person who goes first, they kind of get beat up a little, but it's okay. I tell them, it's going to hurt a little bit, but you're going to be such a better assessor after this, and you're going to be such a better injector. I have fun with it. But I can see how hard it is. But the truest thing is, like, literally, once you see it, you can't unsee it. And they look at it and go, how did I not see that? It's so obvious. Because you have to reprogram your brain to actually accept the information. So that's the kind of fun things we do. So anyway, I think I'm all talked out. But a little asymmetry is aesthetically pleasing. Absolutely. Look at remember when they used to have those cameras that took a picture of your face and then it duplicated this half and duplicated this half into two equal halves, and you look like two different people. It's true of everyone. Look at the model on the front of any cover of any magazine, and you'll look. Sometimes the eyes are too close, sometimes the eyes are too far, sometimes the lips are asymmetric. It's not the micro that's beautiful. It's the macro. It's the full picture. And asymmetry is real, and it's in everybody, and it's attractive. I mean, sometimes they sort of airbrush and everything, but it's real. Like, asymmetry is like, sometimes the most beautiful women have big noses. Sometimes the most beautiful women, their eyes are too far apart, like Cameron Diaz, or other people's eyes are too close together, but they're still beautiful women because it's the entire package that makes beauty. It's not the measurable differences in terms of eyebrow height. But that's something to notice if someone's coming to you and they want to get treatment. You got to point those things out, because if you don't, they'll be like, Russo, that eyebrow was never higher until you touched me. And then if you haven't taken a photograph, you can't disprove that. You can never disprove that. So take photographs before you touch anyway. Hey, Wilkinson, about time you got on. She just comes on now. Everyone's leaving. Does the orchid on your left need water? Yes. No, I actually watered it with the ice cubes the other day. So thank you for checking. She takes care of the orchids at the office and is the orchid whisperer. I see her talking to them all the time. Go get some sleep. We have a big day tomorrow. So I know we're getting close to your bedtime. So anyway, I think I'm all talked out. Anything else I have to say? Any questions that I didn't answer? What were the boils from? We talked about that second case. I think it was from the person contaminating the needle. And what I see most commonly, so let's say this is a needle. People are like wiping it on their arm, wiping it on the gauze, touching the skin with it, touching the hair with it, touching whatever it is they've done. They contaminate the tip of the needle. They stick it into the patient. They put gel in the patient. They're adding the contaminated bacteria to the gel. Voila. Perfect recipe for an abscess. Hello, Megan. So, would have come on sooner. What were you, just out there partying, Julia Wilkinson? So, yeah, I think it's just contamination. So that's bad technique. So if you contaminate needle, look, every box comes with 2 needles. And if you only use one most of the time, you should have a whole box full. What about nodules? Best treatment, dissolve, and what else? Yeah, depends whether it's a nodule based upon contamination and infection, right? So maybe use steroids and antibiotics. If it's a nodule from the fact that some people react to 5-cross technology products, then it's more like maybe some 5-FU, maybe some steroids, maybe just dissolve it with some hyaluronidase, maybe just leave it alone if it's asymptomatic. I mean, you don't have to treat a nodule if it's asymptomatic. Like, usually you can feel something, but if it isn't visible, it isn't bothering the patient, you know it's going to go away. They always do, unless it's an infection, then it just gets worse and you have to. Why are you saying no? Why is Kate saying no? So it really depends, Greta, on what the etiology is. If it's obviously an infection and it needs, emergent treatment, like this patient I talked about, this was an abscess. It was like pus coming out of this woman's face. So it had to be IND'd. If you have an abscess, do you treat with antibiotics? And then no. Abscess has to be drained. It's pus under pressure. If you don't drain an abscess, it can go backwards and go into the brain, and cavernous sinus thrombosis, and all bad things can happen. Basically, your body has kind of walled it off. It's like a pimple that's ready to pop. You gotta pop it and let all the pus out. You have to put them on antibiotics, let it decompress. They put a wick in it to keep it draining. You don't dissolve anything. You just have to incision and drain it. IND it to get the pus out and decompress it. The patient will get better quickly. I was saying it to the comment about people, wiping the needle. Yeah. I mean, it's like an unconscious, like people don't even know they're doing it. They're just like, let me just treat it. And they're just wiping it on their gauze or on their glove and stuff. And it's just a bad habit. And that's where people get in trouble. You don't need much in the way of bacteria to create a problem. And, but I want to be clear that if someone has an abscess, that needs to be surgically treated pretty emergently. I mean, you can put them on antibiotics right away, that's fine, because it may help the spread and slow it down a little bit, but your body's like, please let me out of here. Let's get this pus out of here. It's kind of walled it off. It's kind of saying, here it is, and then you just nick it, and all the pus comes out, and you're good. But that's the problem. It's just, I think it's really bad technique, and if you've ever gotten one of these, you have to really re-examine your technique and make sure that the needle touches the skin as little as possible. Some people wipe with alcohol between every injection. I will never criticize anyone for that. I think that's just great. Being very neurotic and cleaning. No one's ever gonna say you didn't do a good job, but not everyone does it. Some people don't clean it at all or clean it well enough. But even when they do, they're contaminating it. So try to be persistent in that. Anyway, we've been on for a long time. It's been fun. This has been a really interactive and interesting session. I think we'll be back next Tuesday. We may have a special guest. We're trying to work on that now. Any more questions before I sign off tonight? Any last minute questions about any of these terrible complications we talked about? But remember the key point tonight. If you have a patient with an adverse event, do not make them feel abandoned. You're welcome, Sid. My pleasure. I know you're soaking this stuff up, and I hear really good things about you, and we're very proud of you. You're welcome. Thank you. Not only don't make them feel abandoned, but go above and beyond. Call them all the time. Make them know that you care about them. You're welcome, Colleen. Make them feel like you're in this with them, because you really are. And if you don't feel like you're in this with them, you're in the wrong business, because it's heartbreaking when you have a complication or a bad result from the patient. I mean, it should be. I've had a lot of sleepless nights, because I cared about it, and it ate away at me. So they're in it with them. Get them through it together. Don't ever abandon them, because if you do, how about Botox and people on antibiotics, eardrops? I read to have them wait. Botox and antibiotic eardrops. I don't know of any connection between the two. Antibiotic eardrops should have nothing to do with injections of neurotoxin into muscle. So I'm not sure what that means, but I've never heard of it. So be with them. Tell them you'll get them through it. Own it. Control it. Make it better. Make the person happy. Keep them coming back and be successful. Good night to everyone. It's been a lot of fun. We'll see you next week, Tuesday at 7. Check our link in the bio, and have a great week. Bye.